This is cardiac standstill. In man, as in the dog, the consequence of cardiac standstill is death. Over the next several minutes, the tissues of the living organism will become increasingly hypoxic. After 4 minutes, the brain may be irreparably damaged. But resuscitative measures within those 4 minutes may reverse cardiac standstill, start the heart beating again, forestall damage to the brain and other organs, and in short, reverse the death process. How this may be accomplished through a new resuscitative technique will be the subject of this film. Cardiac arrest is an emergency that any physician may encounter at any time or place. It may be due to ventricular fibrillation following myocardial infarction, to electric shock, to asystole due to drowning, strangulation, or suffocation from any cause, adverse reaction to anesthesia, vagovagal stimulation, and many other causes, such as anaphylactic shock. When cardiac arrest occurs in the hospital, the open chest method of resuscitation, popularized by Dr. Claude Beck and others, has become a well-established clinical procedure. This method is, of course, generally feasible only in the hospital. Further research in resuscitation techniques has shown that it is possible to massage and resuscitate the heart without opening the chest. This method, developed at Johns Hopkins, may be used by the physician employing only his 2 hands anywhere at all. Essentially, closed chest cardiac massage consists of manual application of rhythmic pressure to the patient's lower sternum with simultaneous ventilation of the lungs. This is the normal action of the heart and circulatory system. When cardiac arrest occurs, the circulation of the blood ceases. Oxygenation of vital organs and tissues falls off rapidly, though not completely. It is thought that there is generally sufficient oxygen even in static blood to maintain the central nervous system for about 4 minutes. The immediate goal of the physician, therefore, is to restore artificially the flow of oxygenated blood through the circulatory system. He can do this through external cardiac massage and pulmonary ventilation. During external cardiac massage, heart displacement within the thoracic cavity is limited anteriorly by the sternum and posteriorly by the vertebral column. Lateral motion is contained by the pericardium. Depression of the lower sternum compresses the heart and forces blood into the pulmonary and systemic vessels. Release of pressure allows the chest to expand and the heart to fill. The flow of blood is predominantly forward. The heart's valves prevent backflow. The fact that blood will circulate throughout the system under these circumstances can be verified by this laboratory demonstration on an anesthetized dog. Here are Professor William B. Kouwenhoven and Mr. Guy Knickerbocker, who, with Dr. James Jude of Johns Hopkins, developed the technique of external cardiac massage. Dr. Kouwenhoven comments on the demonstration.
This catheter in the femoral artery records the blood pressure. This catheter in the carotid artery shows the blood flow. And these electrodes connected to the electrocardiograph. It is clearly seen that at this time, the heart action and circulation are normal. We will induce one type of cardiac arrest by applying an electric shock. This throws the heart into ventricular fibrillation, a condition commonly associated with myocardial infarction and electric shock in man. In ventricular fibrillation, the heart twitches ineffectually without beating. It does not recover spontaneously. We will now induce ventricular fibrillation. The cardiogram shows that the heart is fibrillating. The blood pressure falls to 0, as does the carotid flow. The animal is in cardiac arrest. We now begin closed chest cardiac massage and artificial respiration. The blood pressure rises and the blood flow comes up. The heart and brain are thus kept oxygenated until external defibrillation can be performed. To demonstrate the effectiveness of this method in maintaining useful circulation, we will continue external cardiac massage and artificial respiration for 1/2 hour before defibrillating. We have been giving closed chest cardiac massage for 1/2 hour. All right. We now give a 1/4 of a second defibrillating shock along the long axis of the heart. Normal sinus rhythm, blood flow, and pressure return immediately. If the myocardium and central nervous system had not been effectually maintained throughout this period of cardiac arrest, successful defibrillation could not have taken place. Here is the resuscitated dog 24 hours later. Responses and reflexes are normal. There are no signs of brain damage or other insult due to hypoxia.
This is Dr. James R. Jude, a co-developer of external cardiac massage.
The heart is predominantly located below the lower 1/3 of the sternum, which may quickly be located by reference to the suprasternal notch and the xiphoid. Thus, in the application of external cardiac massage, the heel of one hand is placed on the lower 1/3 of the sternum and the opposite hand over it. Firm downward pressure is exerted about once a second, so that the sternum is depressed towards the vertebral column 1/1/2 to 2 inches. At the completion of each downward stroke, the hands are completely relaxed so the chest may normally expand. In actual practice, motion is much more vigorous than appears here, but there is little danger of fracturing the ribs in the arrested patient when pressure is properly applied. In any case, the desirability of resuscitating the patient far outweighs this danger. Let us observe how this may be applied in a simulated cardiac arrest during a house call.
Swift preliminary diagnosis of the victim's condition is vital. Does apnea exist? Is there a pulse? Heartbeat? Are the pupils dilated, as is frequently the case in cardiac arrest? If cardiac arrest is even suspected, the wisest course is to act at once without further examination. Make certain there is a patent airway by tilting back the head, then insufflate the lungs a few times. The patient should be on a firm surface, such as a floor, in a supine position. Initiate external cardiac massage at once. Have a relative or bystander call for an ambulance, alerting the hospital to the fact that a cardiac arrest victim is being brought in. If an S-tube is handy, insertion at this point will facilitate mouth-to-mouth breathing. As soon as the other person has completed the call to the hospital, he should be instructed to breathe regularly into the patient's mouth, holding the nose closed. If a third party is not available, the physician should pause in his massage every 30 seconds to ventilate the lungs 2 or 3 times. Closed chest massage of itself does not provide adequate air movement to the lungs. Mouth-to-mouth breathing in cardiac massage need not have the same pace or rhythm. Sufficient force is required to depress the sternum 1.5 inches or 2 inches towards the spine about once a second. Do not apply any pressure on the ribs with the fingers. Use only the heel of the hand. Removal of clothing, except for outer garments, is time-consuming and unnecessary at this time. It is sound practice to pause every few minutes to determine whether heart action has resumed. If it has not, an intracardiac injection of 1/3 of a cc of 1 to 1,000 epinephrine may be given after 2 minutes have passed. It may be desirable to massage the patient's chest at intervals while preparing the intracardiac injection, or to have a third party take over the massage. Once the procedure is well underway, the vital signs to look for are spontaneous gasping respirations, palpable radial, carotid, and femoral pulses, and constriction of the pupils. Cardiac resuscitation should be continued unless the pulses remain strong and the blood pressure normal. It must be emphasized that both cardiac massage and artificial respiration are to be continued until the patient reaches the hospital. On arrival in the emergency room, steps should promptly be undertaken to continue resuscitation or to ensure survival if heartbeat, blood pressure, and respiration have already returned. The external defibrillator and electrocardiograph should be immediately available for further diagnostic and therapeutic procedures. If respiration has not returned, the trachea should be intubated at this time. Positive pressure ventilation should be instituted. The electrocardiogram will indicate the status of cardiac activity. If it reveals ventricular fibrillation, the external defibrillator is applied. It may also be necessary to inject more dilute epinephrine directly into the heart to strengthen the ventricular fibrillation before defibrillation will be successful. The external defibrillator delivers 440 volts for 1/4 second. 1 or 2 such shocks will generally succeed in defibrillating the heart. Sinus rhythm or asystole may occur thereafter. Further cardiac massage may be necessary before the patient will develop spontaneous blood pressure and pulse. If a regular intravenous needle cannot be inserted, an immediate venous cut-down should be performed as soon as possible after admission. Use of continuous vasopressors may be necessary to reverse circulatory collapse. Other drugs, such as 10% calcium chloride or other cardiotonic agents, may be necessary to strengthen cardiac action. Sodium bicarbonate may be necessary to reverse acidosis. And quinidine or procaine amide may be helpful in decreasing myocardial irritability. Vital signs are returning. Nonetheless, the patient will be watched very carefully and the therapy adapted to meet changes in the specific situation. If good spontaneous breathing has not recurred, prolonged artificial respiration may be necessary. If the patient has not yet awakened, he should be taken to the recovery room or intensive care unit and placed under close observation. Hypothermia may be indicated at this point in the absence of spontaneous respirations, normal reflexes, or constricted pupils. These signs are generally indicative of central nervous system depression or brain damage. Remember, too, that though the heart has resumed beating and regular respiration is being maintained, the primary cause of cardiac arrest may still remain. The victim's survival depends now upon specific diagnosis and therapy without delay. External cardiac massage is also indicated in infants who are born without an audible heartbeat. A moderate pressure should be used. Excessive pressure may damage the liver or cause other trauma to internal organs. Since their rib cage is very flexible, children up to 9 or 10 years of age require only the force delivered by the heel of one hand in external massage.
External cardiac resuscitation has been successfully employed at this institution on patients ranging in age from 1 week to 82 years. Of over 100 cases of cardiac arrest treated by this method, 62% have been resuscitated to their pre-arrest central nervous system and cardiac status. Among the survivors is Mr. Eugene Barnes. Good morning, Mr. Barnes. Please sit down. Mr. Barnes is 46 years of age. He collapsed in the emergency room over 1 year ago. He came complaining of severe substernal pains radiating down both arms. While undressing, he suddenly collapsed to the floor and took several gasping respirations. Following this, his respiration ceased. There were no palpable pulses or blood pressure. External cardiac massage was immediately begun by the attending house officer. An electrocardiogram revealed his heart to be in ventricular fibrillation. Assisted respirations with oxygen by way of an endotracheal tube were begun after 10 minutes. External cardiac massage was continued for 23 minutes. At that time, an external defibrillator had been obtained and 2 countershocks, 3 minutes apart, were applied. Spontaneous cardiac rhythm ensued. The patient was hospitalized, treated for his anterior myocardial infarction, and discharged 6 weeks later. He has been symptom-free since that time. Mr. Barnes, have you returned to your old job?
Yes, sir, I have. I returned to my old job driving a concrete mixer.
That sounds like rather heavy labor. Have you had any difficulty with it?
No, sir, I have not.
As compared to your health before your illness, have you or your family noticed any difficulty in your remembering persons or places or things?
No, sir, I have not.
Your memory is just as good now as it was?
Yes, sir.
This has been quite an experience for you, Mr. Barnes. Do you feel as well now as you did before you had your heart attack?
Yes, sir, I do.
Thank you very much, Mr. Barnes. To be effective, as they were in this patient's case, resuscitative procedures must be undertaken promptly. We recommend that both the physician and the hospital know in advance the exact steps they will take to reverse cardiac arrest.
To sum up, when cardiac arrest occurs outside the hospital, the attending physician should, 1, observe vital signs. Check breathing, pulse, and heartbeat. If there is reason to believe that the arrest is very recent, he should ventilate the patient's lungs and begin external cardiac massage. Then have the hospital notified that a cardiac arrest victim is involved and ambulance and equipment needed. 5th, he should inject intracardiac epinephrine if necessary. And 6th, continue external massage and ventilation if needed until the patient's arrival at the hospital. Once inside the hospital emergency room, continue external massage. Artificial respiration with oxygen should likewise be continued using intubation and positive pressure breathing apparatus. 3rd, take electrocardiogram and prepare external defibrillator. If the EKG reveals ventricular fibrillation, apply external defibrillator. Give intracardiac or intravenous drugs as indicated to combat hypotension, acidosis, myocardial irritability. 6th, have a second team perform venous cut-down if necessary. 7, begin continuous administration of vasopressor drugs according to patient status. Continue external massage until pulse and blood pressure return or signs of central nervous system or cardiac death are unmistakable. Finally, following revival, continue diagnostic and therapeutic procedures as indicated. External cardiac massage has proven its effectiveness in many cases of cardiac arrest. It is indicated in asystole as well as in ventricular fibrillation where circulatory standstill has taken place. The method provides adequate circulation to maintain the heart and central nervous system until the heart itself can resume beating. To use external cardiac massage effectively, the physician and the hospital resuscitation team should know in advance the steps each will take to reverse cardiac arrest when it occurs. They should keep in mind at all times that promptness, pressure properly applied, and ventilation are keys to the success of the method.